Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Joanna Richey. How you doing, Joe?
Hey, Jeff, I'm doing well. How are you doing?
Life is good. I can't complain. Weather's cooling off in Arizona.
Yes, it's lovely outside.
It is lovely. Well, we have a phenomenal guest today for Dean's Chat in the wound care space. And the timing's great because last week in Arizona, we had the Desert Foot meeting. All three of us, I presented at that meeting. So it's kind of fun to get together and discuss chronic wounds. So I'd like to welcome Dr. Wendy Cole to Dean's Chat. Welcome, Dr. Cole.
Thank you. Thanks for having me. I'm very excited to have our conversation tonight.
Oh, thank you so much for joining us. What I'd like to do is kind of give you a little bit of a formal introduction. But before we do that, we're pretty informal here, Dr. Cole. Are you good with Wendy, Joe, and Jeff?
Yep. Perfect.
All right. That sounds great. Well, Dr. Cole got her undergraduate degree from the University of Cincinnati. She's a graduate of the Kent State University College of Podiatric Medicine. She's practiced in Ohio for approximately 22 years. Currently, she's an adjunct professor and director of wound care research at the Kent State University College of Podiatric Medicine. Dr. Cole is board certified by the American Board of Foot and Ankle Surgery, as well as the American Board of Wound Management. She's extremely well published, which we're going to get a chance to discuss today. She's a fellow of the Royal College of Physicians and Surgeons in Glasgow. She's on multiple advisory boards. No shortage of things to talk about. Welcome again, Wendy.
Thank you. Thanks, Jeff.
All right, let's get started. Joe, you mind if I kick it off?
No, go for it.
All right. So, Wendy, it's always fun to talk to people that are involved with research within the colleges of podiatric medicine. And your role, certainly as an adjunct professor and overseeing wound care research at Kent State, has made a tremendous impact, not only on clinicians and patients, but also students. And I was just wondering if you could talk about, how you got that set up, your research facilities, kind of some research that you're doing, and that may give us a springboard to launch into further discussions.
Oh, absolutely. I'm happy to talk about that. Kind of like my little project, if you will, passion project. About, 15 years now. Well, even before that, let's go back, way back. When I graduated from residency, I had my solo practice. I did general podiatry for many years and started to get involved with wound care formally when our hospital center opened a wound care clinic. And they asked several of us clinicians if we'd be willing to work 1/2 day a week at the wound care center. And I was seeing some wounds in my office, as we do as podiatrists, a lot of diabetic foot ulcers. And I thought, well, that would be great. I didn't have any formal training in wound care back when I went through the college and did my residency. We didn't really rotate, and I don't think wound care was really what it is today. So I learned a lot in those first few years of doing wound care at that hospital-based outpatient center. And I really thought, this is what fuels my soul. And it's what we call a sheet kicker, right? It's what makes me kick the sheets off the bed in the morning. And I had so many questions about the pathophysiology, the different products. And again, it's funny to think about it, but wound care was kind of a fledgling subspecialty at the time. So I started to take more time away from my private practice and spend it in the wound care center. And then I was asked to join another wound care center in a town about 45 minutes from me. And through all of this interaction with wound care, I got to know some industry representatives, and I was asked to do some trials and not RCT level trials, but more evaluations of new products. And I loved it. I loved trialing new things, seeing how the patients responded, determining what patients are, appropriate for what therapies, and determining these algorithms of care. So then that blossomed into actually moving completely away from general podiatry and focusing on wound care full time and wound care research. Subsequently, I was still involved with teaching the residents, and I was, kind of surprised that there wasn't more interaction with the residents in wound care. And even as the students, they weren't really getting a baseline of wound care education. So went back to the college, probably about 8 years ago now, wrote up a proposal for a wound care research department. And it took a while, as you know, in the colleges, there's a lot of meetings and a lot of red tape that you have to wade through. But we've been up and running at the college for probably 7 years and doing wound care research there. And we've really done some pivotal trials there, and we're continuing to make a wave in the industry and introduce the students to research, which I think is so important, and wound care, because not every podiatrist wants to be a surgeon, or maybe should be a surgeon, to be honest with you. And there are different avenues, and we have to really expose the students and the residents to other avenues. And I just love wound care. So I'm a big cheerleader for research and wound management.
That's fantastic. A couple of thoughts came to mind right away. One is, hats off to all the management companies over the last 30 plus years that have really instituted hospital-based wound care centers and really wrote protocols that involved a multidisciplinary team, because that was really the beginning of all of us working together, whether it was vascular, infectious disease, podiatry, et cetera.
100%.
It's not today what it was 30 years ago, that's for sure. Joe, your thoughts?
Yeah, I love your statement, Wendy, about the sheet kicker.
Yes.
And to your point, like having the opportunity for students to engage in so many different facets of what podiatric medicine has to offer, I think is so spectacular. And not just from exposure to wound care, but also wound care research, which, to your point, this is an evolving field. It's evolved over the last 10, 15 years, and it's only going to continue to evolve. And I know we're going to continue to talk a little bit more about that. But before we get too far ahead of myself, over the last 15 years, maybe, what do you think has been the biggest progress that's been made, or discovery, or maybe not product specific, but technology wise? What do you think has been the biggest shift in what we see and how we practice now compared to maybe what we were doing 15 years ago?
Well, I think that we are starting to be proactive and not reactive, which I think is really important, because as we've discussed, it's really a changing field, and we're understanding the pathophysiology behind why these wounds become hard to heal, right? We know that my children, they hurt themselves, and within a day, even a pretty decent sized gash is, healed up. Whereas we get older, we have some complicating protoplasm, right? We get comorbidities. Our skin turgor is not what it used to be. So there are quite a few hurdles that will kind of derail that wound healing process. And we're better understanding what those things are because we're learning about the different biomarkers, and we're getting to be more personalized in our care. We can understand what biomarkers are off with our patients, what other contributing factors. So we've said the old adage, treat the whole patient, not just the hole in the patient. So really understanding, doing a thorough patient assessment and wound assessment is so critical. And I think that that's really our best tool in our bag still, is a good wound assessment and patient assessment, a good history and physical. But we are getting really exciting tools also that are entering into the space, like diagnostics is what I refer to them as. So advanced imaging tools that could diagnose a problem. So maybe hypoxia. So near infrared spectroscopy is an advanced imaging tool that could tell us how much oxygen is attached to the hemoglobin, so we could see what the functional perfusion in the wound. So we can ABIs and other non-invasive vascular studies can tell us about the macrocirculation, but we know that our patients, especially our diabetics and those with PAD and PVD, their microcirculation can be a problem. And until some of these advanced imaging technologies have come into the market, we really weren't aware of the functional perfusion. So now we can manage that biomarker. So it's a diagnostic where it could diagnose if there's hypoxia, but it can also tell us if our therapies that we're applying are successful, because we could better measure what we're managing. So we could see if there's an uptick in oxygen if we apply a certain dressing or offload or what have you. Same with fluorescence imaging. We could see bacterial loads on the wound, so we could tell if our debridement has been successful or if we need to use some sort of topical antimicrobial or systemic antibiotics, so we could better tailor our treatments. We have our temperature, thermal imaging that could show us pressure, or if there's inflammation that might be indicative that the wound is about to deteriorate or become infected. So I think that's where we're at. We're getting all of these technologies, these diagnostics that can determine the biomarkers. So it's not just like, oh, well, we'll throw a dart and say, oh, we'll use this dressing or this therapy. Oh, 4 weeks later, we see Mrs. Jones and it didn't get any better, so let's throw another dart at the wall. Oh, well, let's try this therapy. We could really hone in and be better attuned to what's going on with our individual patient and practice better medicine.
Yeah, I think that's such an exciting opportunity. Also, having each of these little, as you described, we just spent 4 days, 3.5 days talking about all these incredible new opportunities for technology and how we can engage with it. And if we look at medicine across the spectrum, precision medicine is becoming so much more of an emphasis in each of these own little areas of nuance. It's no surprise that it's also happening here in podiatric medicine. So I appreciate that. Again, diagnostics. I'm getting all kinds of great words from you today. I'm gonna have to start taking a note.
So I have a question for you, Wendy. This is just what I see out in the world today. Podiatry puts a huge emphasis on peripheral vascular disease assessments or screenings, if you will. And I think that's really important in a wound center. If we find it, we test them, we send them off to the appropriate place for intervention, vascular surgery or interventionist. But I've always thought from a podiatric medicine perspective, we should be screened for neuropathy, because it's neuropathy that we are directly related to when it comes to the wounds, infected or with or without peripheral vascular concerns. Your thoughts on that?
Oh, Jeff, this is a lovely topic for me.
This is why you're here, Wendy.
It's a soapbox issue for me. Okay, so yes, we do, I think, a fair job of screening for PAD in our patients, our diabetic patients with diabetic foot ulcers, right? So we'll get our non-invasive vascular studies, our ABIs, but we know that those can be false positive and false negative, right? So our patients with diabetes can have arteriosclerosis. They could have hardening of the arteries, calcifications that can give us a falsely elevated ABI. So we can think they have good macro perfusion when they really don't. We're just getting calcified vessels that appear to have a decent ABI. And then also sometimes they're too calcified, we can get no ABI. So we can't even check the macro circulation. The other flip of the coin of that is the neuropathy, like you mentioned. So I think as podiatrists, we're good. We take out our tuning fork, hammer, and our Sims-Weinstein monofilament wire, and we test our diabetics, and we see if they have sensation. And many of them have peripheral neuropathy at some point, right? But we don't talk about how those two collide. And it's very important, because even though we get peripheral neuropathy with diabetes because the high glucose levels are toxic to the nerve, and we get cytotoxicity in the nervous tissue, what will also happen is not just the sensation, but the autonomic nervous system will be a problem as well. So what happens in our diabetics, even if they have good, quote unquote, macro circulation, so they have a good ABI, we did our due diligence, we did our non-invasives, they have a good ABI, they can have microcirculatory issues due to neuropathy because the autonomic neuropathy can be at play. And what will happen is they won't be able to vasodilate or vasocompress in response to stresses. So we actually at the college are doing a study, and I had a poster at SAWC, and we're finishing up the scrub of the data. But we had two cohorts of patients. We had our quote unquote normal patients, so non-diabetics without neuropathy, mostly the students at the college, I'll just tell you. Those were, that was that cohort because I could grab them and make them do the test. And then we had diabetic patients with diagnosed neuropathy, and we used the Michigan neuropathy scale. So it was a questionnaire, and they had to have positive marks on the neuropathy scale, and then also with their Sams-Weinstein monofilament and the tuning fork and the hammer, they all had to show that clinically they had peripheral neuropathy. We subjected both cohorts to different stresses. And so the stress was 20 minutes of elevation of their limb above heart level, 20 minutes of elevation of their limb, so hanging over the side of one of our exam tables, then 20 minutes of heat and 20 minutes of ice. So then we did imaging with near infrared spectroscopy to see what the oxygenation of the tissues was like. In our patients that did not have neuropathy and did not have diabetes, our body was able to maintain a steady state of oxygenation in the tissues after all those stresses. So you saw that it was relatively stable in our healthy cohort patients. And our patients with neuropathy and diabetes, all over the place. After these stresses, they weren't able to react. So they basically have functional ischemia, even though they have good macro circulation. Their micro vessels, they just can't respond to pressure or heat or cold. And so they have this functional ischemia that then is problematic, and it's going undiagnosed, completely undiagnosed.
Wow. My brain immediately went to the IRB approval to take a neuropathic patient and put him in ice for 20 minutes.
It's an ice pack.
Oh, gotcha. Okay, gotcha. No, that's fabulous. Hey, so that's great for the students. They get involved in research. They get to be involved in protocols. They get to be involved in IRBs and actually carrying out the research, informed consents and things. Wow.
Absolutely. Yeah.
Well done, Joe. Your thoughts?
Yeah, no, and like there's so many different things that my mind wants to go to that I don't want to get super off topic though, because I know there's a lot of other things we want to talk about. But even what you were just talking about in terms of future and opportunity, even the idea of some of the wearable tech, and we haven't figured it all out yet, but being able to help monitor these phenomena in patients, maybe one day reverse or cure or whatever, again, as we start to understand more of the pathophysiology. But even if we can't get to that point, just being able to find ways to intervene and be preventative on your side, being more proactive than reactive. Again, this is such a breadth of untapped knowledge that we're venturing into, and I just think it's terribly exciting.
I agree. And the wearable tech, I think there's a real niche that will fill, as you mentioned. Up till now, I'm focused on treating wounds, right? But where are we at with the prevention of wounds, And so that's where I think if we have better screening tools, like, some of this technology we're talking about, if we could pick up when patients with neuropathy are having that microcirculatory issue, maybe there's something we could do to prevent skin breakdown, because we know that they are more apt to break down their skin and develop ulcers. And then when they develop an ulcer, we know what happens, right? The recidivism rate for diabetic foot ulcers is very high. Infection rate, they end up in the hospital. If they undergo an amputation, we know their morbidity and mortality skyrockets. So we need to get ahead of this. So we need to start looking for these screening things with our patients to see, okay, well, even though they have good circulation, or we think they do from the non-invasives, from the historical way we kind of monitor these patients. With these new technologies, I think there's better ways to monitor and kind of keep a closer eye on these patients so they don't deteriorate.
Yeah. Excellent.
Totally agree. Since we're all fresh off the Desert Foot meeting, all of a sudden I'm thinking about Gary Rothenberg and Podometrics and skin temperatures in the honoring Paul Brand's early research. Wendy, when you were here last week in Phoenix, what did you give your talks on?
Oh, so I had 2 talks. So it was offloading of diabetic foot ulcers.
Oh, that's nice, near to my heart.
And debridement, offloading and debridement of diabetic foot ulcers, and then diabetic foot infections. So treating diabetic foot infections. And that's another soapbox issue, is that we as podiatrists, medical specialists in general, wound care included, prescribe too many systemic antibiotics, and we're causing a problem with antimicrobial resistance. So I think we need to be a little bit mindful about, how we diagnose these things and then how we treat these things, especially in wounds. Not every wound needs to have or not every patient with a wound needs to have a prescription of an oral antibiotic, even though the patients probably think they do. And they're always asking for it, right? So just being more mindful and using some of these alternatives to systemic antimicrobials to treat the contamination, because we know these wounds, unfortunately, have been open many weeks, many months, many years. So they are contaminated with bacteria, although they probably aren't clinically infected. So doing good wound hygiene, wound debridement, offloading, and teaching our patients about good practices and good hygiene is really a really good place to start.
Very good. What was the highlight of the offloading lecture?
Well, I think that we know that some of these new technologies for offloading can be more palliative to the patient and palatable to the patient, I should say. So, we always said that total contact cast is kind of our gold standard because it's a non-removable offloading. We know it reduces plantar pressures very well, better than most things. But there are some new and novel offloading devices that are coming into the market that are showing that they're offloading equal to a total contact cast. But the problem is the forced compliance is not there. But there's a new and novel offloading boot that is lockable. So if you have a cantankerous patient that tends to be naughty and remove their offloading, and you're just not getting anywhere with them, you can actually have them in a boot, which can be easier to walk in, and it's less heavy than some of the total contact casts. And you could give a key to a home healthcare nurse or to the spouse, and they could do dressing changes. So that's the other thing that a lot of people don't like, is once you get a total contact cast on, in order to change the dressing, you have to remove it and reapply it. So with a locking boot, you can have a trusted caregiver, either formal or informal, be able to remove it, and the patient still has that walking boot that's about the same height as like a tennis shoe, so it doesn't throw their gait off. So I think there's some new hybrid technologies in offloading that patients will be a little bit more agreeable, but then allow us to have, the ability to remove it to do what we need to do for the wound.
Very good. I got a funny story to tell you. So with the total contact cast EZ, we've got that black outer boot that patients like to take off. So at one point I put a lock on it, which was a numerical lock. It was like 000, 3 numbers, right? So I'd put it on the patients, and then I'd spin the numbers, and then they didn't know how to take it off. So they'd go home and they would literally go 001. 002 until they crack the code. And then they'd come back in the office and say, Dr. Jensen, I cracked the code. And I said, but you didn't take the boot off, did you? And they said, no, but I know they did, right? You could see on the bottom of the cast.
I'm sure you have too. I've seen patients at the grocery store, the county fair, when they're supposed to be wearing their boot. I walk up to them and they don't think that I have a life outside the office, right? Like I don't go to the grocery store.
One other...
you see them. Oh,
One
go
other
ahead.
funny story. My wound care center was at the hospital. And so I'd be down having lunch and I'd see my patients walking around with crutches on their shoulders. And then they'd come limping into my office with their crutches.
Right.
And I'd say, I saw someone who looks just like you in the cafeteria with his crutches on his shoulder. It was hilarious. But that goes to show you, no pain, no perceived problem, right?
Right. It's a I mean, it's a double-edged sword. You're glad they're not in pain. But gosh, they just walk around like there's no problem. And it's usually, from the urging of a family member or the wound starts to smell. That's what usually gets them into the clinic. It's not even, that they have a wound because they don't feel anything. Same sort of situation. The wound care center that I used to work at it would overlook the parking lot. We were on the second floor. So you could see the patients park. You could see them get out of their car. You could see them, take off their regular tennis shoe and put on their boot, or, walk in with their boot and probably do it in the lobby and then come up all the time. I'm like,
Yeah, I'm not a huge fan of this partnering with the patient to agree to stay off their foot, because I saw thousands of patients. I probably put on 15,000 total contact casts. We put on over 1,000 a year. And if you give a diabetic patient who's neuropathic an opportunity to not wear their device, they won't wear their device. Armstrong proved it. That recent study out of, where was it? Jordan in Australia. It was a joint study. So yeah, I think the lack of pain just throws everything off, because for the obvious reasons. But I wanted to switch over to Joe. Joe, I went to your lecture on Friday night on diabetic infections. I meant to tell you, Alexandre Lemy-Godoy, who was the author of one of your studies, I used to work with him. He's from Brazil.
Huh.
Yeah, he's great.
Fantastic.
But how about your lecture? What was your lecture on for the most part at Desert Foot?
Very much around neuropathic patients and what are the risks that we need to be mindful of when we consider surgical intervention. So
I thought it was excellent in terms of
thank you. Yeah.
stage procedures and outcomes. And like Wendy, like you were saying earlier, we got to follow the evidence. And there's not a lot of evidence on some of these topics.
And it's stuff that's interesting because it's things that we all presume are the underlying etiology or the deforming force. But when you actually dive into what has been published in the literature, sometimes there really isn't a lot of support. And so we had been talking, this is a nice little transition, Jeff. Wendy, we had been talking before we started about some of the importance behind research. Can you talk to us a little bit about your perception or your opinion about why bother? It's, it's lengthy, it's exhausting. There's a lot of red tape involved. Why should we be doing high quality evidence-based medicine?
Yeah, well, I think you hit the nail on the head, right? We assume a lot of things, and we know what happens when we assume, right? So I always say the evidence made me do it. I do things based on the evidence, and we really should be having that mindset. But to your point, a lot of things and a lot of conditions, wound care, podiatry, all across, all stages and facets of medicine, there is evidence that's lacking. And that's how I initially got started in research. Is I had all these questions and I would go to do research, lit searches, I should say, on, okay, so what is this condition and how do we treat it? And, what's the percentage of patients that benefit from that certain treatment? And there was this paucity of evidence, of really good, high quality evidence. I mean, maybe there was like a case series, prospective single arm case series, which is great. We need real world evidence. I'm not poo-pooing it. But we really need high quality evidence too. So the high quality evidence, the randomized controlled trials, the meta-analyses, then you use the real world evidence to prove that translates into the patient population that we treat on a daily basis. So I think it's really important for us as podiatrists to get into research, because we should be the diabetic foot experts, the wound care experts. And I'll tell you, we talk a lot in podiatry about parity, right? We want parity with our MD and DO colleagues. And in my 20 some odd years of practice, nothing has gotten me parity better than being the diabetic foot expert, right? I have the infectious disease docs calling me, primary care docs calling me, the vascular docs calling me. And, not only am I I have a seat at the table, but most of the time I'm at the, lead of the table in these conversations around these complex at-risk patients. And so really understanding the problem and understanding how best to treat the problem in our patients by doing research and generating evidence and building those evidence-based care algorithms is so important to help our profession excel and really be the leaders around these problems that we treat every day.
So well said.
Thank you.
Before we leave that, can I piggyback another question?
Yes, but I
kind of in the
want to
same
come
line
back
of
to it
thought?
too, because I
Okay,
I
then I'll let
agree,
you go
both
first,
of
Jeff.
us. Oh, all right. So I wanted to highlight, we were at Desert Foot last week. It was Dr. Bob Freiberg in his book, The High Risk Diabetic Foot, where he was highlighting podiatrists being like the quarterback or the central team member who would see the patient, assess them for all the things we've been discussing, and then bring in the specialist, be it vascular, infectious disease, with the dialysis, bring in, and then the endocrinologist, et cetera, and podorthics, right? There's a place for everybody.
Oh, gosh, yes.
But
Oh,
I wanted to
definitely.
throw a plug in there for Dr. Freiberg because he was one of the leaders driving evidence-based medicine and podiatry and wound care early in the game. Sorry, Joe. I just had to throw that in
Oh,
there.
Bob's
No,
a
that was
leader,
awesome.
and I look up to Bob, and I call him a friend now, which is great. But I agree. I think we really are the quarterbacks of the team. Wound care is a team sport, no doubt. It's interdisciplinary, not multidisciplinary, because it's interdisciplinary. We all overlap and work together. But podiatrists are really at the head of that team, and it's really important. And if you don't have that knowledge base and you're not doing research or contributing to the evidence, I think that you're missing out.
Fair enough. Sorry, Joe.
No,
cut
no,
you
this
off.
is great. You're building me up even more for where
Okay,
my
sounds
thoughts were
good.
going.
Sounds good.
Because just some other things that you're also involved with, Wendy, the multiple editorial boards looking at different evidence-based medicine, and one of them even things like ePlasty, so plastic surgery, infectious disease, diabetology, endocrinology, nephrology. And to your point, we work collaboratively for the success of the patient. And so my next question that I wanted to kind of piggyback was, as there are so many opportunities and products that are out there, how do you then start to decide, or what is it that you look at when you're deciding to trial something new? Like, how do you determine, all right, there's, product X that just came out. Here's all the industry sponsored stuff that they're sending me about how successful it is. What is your thought process in terms of incorporating new technology or new products for wound care, and how do you kind of stratify that?
Well, there always is something new, right? Someone knocking on our door, and you want some evidence. I mean, maybe if it's a new product, you understand not having, a large randomized controlled trial of 200 patients. You understand that if they're just getting started, but you want at least some benchtop animal toxicology evidence. If someone comes to me and they've got absolutely no evidence to show me, or maybe they have 5 case studies from Argentina or something, you know what I mean, I have a real problem. So I really want to understand what makes that product tick, right? So what's the mechanism of action, or at least the suspected mechanism of action, so that we could start to understand what patients would benefit from it, right? So the other problem is, when someone comes to me with a product that does everything, I can guarantee you it does nothing, because you can't do everything well. If there was one product that did everything, we would all be out of jobs, right? So I really want whoever's coming to talk to me be knowledgeable, have an understanding of the product, the ingredients or the makeup of the product, and what the suspected, at least, mechanism of action is, and at least some efficacy and safety data, even if it's just, on pig ears or whatever, I don't really care, at least some foundational. Then you can determine, okay, well, this is an intriguing product because it does XYZ and it's made of, whatever. let's see what other evidence we could generate. And so I love the emerging biotech space. So when I go to any industry function, any symposium, and I walk through the exhibit hall, I always walk the periphery first, because the big guys and gals, they're in the middle with their fancy booths, and most likely they've got good clinical trials. And a lot of them I was part of, which I'm very proud of. But they're pretty well on their way. They've got their talk track, they've got their evidence. Not that they're not generating new evidence, but the really interesting products are the ones along the wall, the ones, by the bathrooms in the back of the room. And you want to talk to them and see what's on the horizon. And a lot of these products come from overseas, and they're trying to get a footing in the US. So they need guidance through FDA. And then, of course, they'll need that evidence so that they have coverage with CMS and the other payers. And I think right now where I'm at, that's really exciting to me, because I could bring those emerging biotechs into the college and introduce the students to research on really new and novel products. So, if I'm going to use it in my clinic, I really want the evidence to be there, at least some evidence, because we always say the evidence made me do it. So I need some evidence. But if I'm putting my researcher hat on, I really want to help to generate that evidence so that when they go to talk to a doctor, they could give some good quality data. So it just depends on which hat I'm wearing. If I'm wearing my research hat or my clinician hat.
That's excellent. Thank you.
That is excellent. Thank you. You brought up something earlier, Wendy, which I think is kind of the heart of the needs in our profession. How do you encourage more research at all levels, from practitioner to residency programs to the schools to the students? Your thoughts on that? What does it take? Is it something simple? The easier it is, the easier it is to adapt, right? Adopt, I should say.
Yeah,
but your thoughts?
absolutely.
I've got some of my own ideas, but I'm always interested in more.
So I just encourage the students, if you're out on a rotation and you see an interesting case presentation, learn about it, write it up, write it for a poster, write it. Then you can attend a symposium, you have your poster there, and then it's so easy to translate a poster into a publication. It might not be a peer-reviewed publication, but Podiatry Today, Podiatry Management, they are happy to take interesting case reports. So this just happened at Desert Foot. One of my former students, who is now a resident, she got third place in the residence in the poster presentation abstracts. So she was like all excited, because we had worked on posters together when she was a student, and she went to APMA with me, and I got her a scholarship to go to the APMA National. And so now I'm so thrilled that she's continuing to do these sort of things in residency. And I'm like, well, we need to write up that case. So I know you can get that into podiatry management. It was an interesting case of what they thought was an athlete's foot that turned out to be a bullous disorder, or bullous pemphigoid, right? So it wasn't responding well. It was an atypical presentation. So she decided to dive in and see what could be going on with this patient. And it was just a great case. So an interesting case, or just having an inquisitive thought, okay, I wonder what happens when we do this, or I wonder, what's going on with this patient because they have this, and diving into it and writing just one little case that you turn into a poster, that you turn into a publication, that maybe then you have an extended case series on multiple patients. And then, maybe you do a formalized trial with, randomization. So you have a control group. So that's sort of how it builds. That's how it built for me. I just started doing interesting cases on products or presentations, and did abstracts for a symposium that we turned into publications. And now I counted today, because someone asked me, because they were doing a presentation and they wanted to know how many peer-reviewed journal articles I had, and it's close to 50. It's over 50 at this point in time of peer, and that shocked me, because I never counted. And I probably have 100 non-peer-reviewed just publications, articles in our trade journals like Podiatry Today and Podiatry Management, and that's just been having questions or having interesting presentations that I wasn't even sure what was going on with the patient. I'll be like, well, I'll have to get back to you. I'll see you next week. And I'll have a lot of answers for you because I'm really not sure what's going on, but I'm going to find out.
I like that. Joe, what are your thoughts on, every day we're working with our students on different research projects. I think it's a great way to lay the foundation, but how do we get residencies, docs in practice that have access to all the patient data? How do we get them involved in a lot of this?
Well, and I think that's the beautiful thing about having the student engagement is you spark that curiosity at the student level, and they carry that with them. Some students may gravitate more to programs that already emphasize research. Some programs that's very heavily research oriented. Others are, we expect you to publish something and we'll support you, but maybe it's not, we expect something every year. Some programs are totally hands off, like we don't care whether you do research or not. And some programs, they don't even talk about research. And so it's a good question for students if they know they want to do research, they have a lot of curiosity, they really enjoyed that opportunity as a student to engage in it, and they want to continue to do it. I tell them that's a great thing to ask the residents, what kind of exposure do you get, or what kind of support do you get? It's an easy one as you're kind of filtering all the different opportunities that are out there. Again, if hey, I really like this opportunity. And as you and I, Jeff, have talked about, it's one of the easiest ways to really distinguish yourself on a CV, even as a job applicant. So not just to residency programs, but when you're going out and trying to find really good job opportunities, if you've published something as a resident, that really does set you apart. So again, at one point, one of my mentors had said that's the single best thing that you can do to promote your own career. And I obviously fully agree and support that idea, being a big research person myself. But I think it's fair to acknowledge that it's not everyone's cup of tea, and it's not something that all students love doing. And to slog through it when you are not enjoying it, that's not the right approach either. But I think to Wendy's point, it doesn't have to be hard. Come up with this was really interesting. I saw this patient and we thought that it was tinea, and we come to find out through X, Y, or Z, it wasn't. It was actually this other condition. That's research. It does start that small. It doesn't have to be come up with a protocol, get your informed consent, and all of the layers of complexity. You can start with that little curiosity and then grow from there. And then maybe that one little case study is I'm actually really interested in bullous, pemphigoid. What do we know about that? And then you start looking and you're like, I wonder how I could apply that to my profession, right? And that's where you start getting people to connect the dots inside and outside their own field. And that's really where innovation starts to explode. And there's so much engagement and opportunity in so many facets of technology, and that I think the limits are endless. It just comes down to that spark of curiosity. So I loved that, Wendy, that you had said case studies, because that's how you start.
You're seeing a patient like that with an atypical presentation, probably 100 of your colleagues that have seen a patient like that and didn't know what to do, right? Or there's 200 colleagues that are gonna see a patient like that. And if you could help them understand what worked, what didn't work, and then, you set the tone for those atypical presentations that might not be so atypical, but you might come to find out it's pretty common after a while. And that's just all you need. And it is really great too, like you said, on your CV or your resume, because it just shows you're a critical thinker. And even if you don't go into research full time or on a daily basis, being a critical thinker when you're a physician or just a person, it is really a great skill. So doing research really enhances your ability to think critically and ask questions and, really dig into data, which will parlay you to the next level of your career, regardless of where you choose or what you choose to practice in.
I so agree with that. I have a question for you, Wendy. Over the years, I've published, peer-reviewed and some of the journals. And sometimes I read Podiatry Today or Wound Management, and I think to myself, oh my God, this is so close to being publishable in a peer-reviewed
Right.
journal. What are your thoughts on that? And I ask because there's one part that says, you follow the path of least resistance. You can always put it into Podiatry Today or Podiatry Management, but to get it peer-reviewed is like night and day. That's the holy grail, right?
Right.
So where do you make that distinction? Is that a fair question?
Yeah, I think so. I think it depends on, well, who you want your audience to be, because obviously Podiatry Management, Podiatry Today, they're more accessible, right? Most of us get those periodicals, or we have access, online to those periodicals. So I think the distribution is a lot wider for those. So if it's something that like an interesting case, I think you could go peer review on one singular case, but sometimes you just want to disseminate the information. And so having a periodical like we're talking about is better because of your audience. But yeah, and it's not easy to publish. I will just say it is not easy to publish in peer-reviewed journals, right? It's a hassle. You have to pick the journal. You have to understand what they require for their authors. You have to upload documents. You have to go through the review process. And I will say, I don't think I've ever had a peer-reviewed journal article accepted without revisions.
I don't know that anybody has.
Yeah. Some can be more minor than others, depending on the day, depending on the mood of the reviewer, so then you have to go back and rework it. Sometimes there's a cost involved. There's a length of time involved in that too, from when you submit to get the review back, to revise, to get it re-reviewed, and then to get it published. Sometimes it could take a year. I've had it take a year, unfortunately. So I think you have to look at that too. If it's something that's very timely and you want out and disseminated quickly, maybe a periodical like Podiatry Management or Podiatry Today is your better option, because it's going to get out there and be seen quicker sometimes than a peer review. So it just all depends on your bandwidth, your audience, your timeline, and where you should, go with the product. What's nice too is a lot of these publishing houses are doing a lot more with these publications, both peer-reviewed and the periodicals, and generating content on all aspects, right? We've got podcasts like yours, so great. And then they're doing data, they're pushing out data on recording, so video, little blurbs, so it's great that we have all of these avenues to get that information out there. So I think they're getting wise to, maybe not everyone's going to sit down and read, a 5,000 word journal article. But if you can give them kind of the highlights so that it might pique their interest, then maybe they'll go and read the journal article. And I think we're getting a little bit more savvy to getting the information out.
I agree with you. And Warren Joseph's my buddy and our buddy. I mean, we all work with him. But I remember I put an article in, got it in 2016. And it was not when it was done with revisions, it didn't get published for 2 or 3 years. Just the way it is,
It's taken me a year or better to get it in JATMA, and I tell Warren all the time.
Well,
but yeah.
and Joe, for all of our interests, I mean, we have a paper coming out in JATMA on student recruitment and awareness of our profession, and I'm hoping to kick it out sooner rather than later. But it's kind of somewhere, I don't know.
Yeah, it's in the ethos somewhere.
Yeah.
I don't know. I'm going to text Warren when we're done and see.
Well, that's what and I'm guilty of that, because before I even submit, to Joe's point, I sit on a lot of the editorial boards, right? So I really don't submit unless I'm on the editorial board, because then I could tell the editor, hey, by the way, and I don't want special treatment as far as revision, but I would like it to move through the process at the most expedited way, So I always give them a heads up, hey, I'm doing a submission. If, you could get it through, that would be great.
Hey, you got to do what you can.
I know. It's good to have friends in low or high places, however you look at it, right?
And as a plug for Warren too, one of the biggest limitations is getting people to review.
And that's a good point. We should talk about that, because that's a good way to contribute. I mean, so maybe you don't have the bandwidth to do research and you don't want to publish, but wow, if you can act as a peer reviewer, I think it's so beneficial because even though we are kind of tongue in cheek and saying I never get anything back without revisions, and sometimes the revisions are like, really, man, is that really? But I'll tell you, 99% of the reviewers' comments make the article or manuscript better.
Absolutely.
Because you're like, well, I assumed that that was clear, but obviously it's not. Or someone sees, a gap of where we didn't report on something. I'm like, how did I miss that? And you go back and it's better. So if you can't or don't want to do the research, if you could just act as a peer reviewer and give your opinion based on your years of knowledge in treating patients, and I think that's a great way to contribute to evidence. So that's a great point.
Absolutely. Absolutely. All right. Well, we're running a little short on time. I thought I'd give each of you just a chance for last words on recommendations for research for our students. Joe, you want to go first?
Oh, I don't want to take, I will talk forever. So I'm actually going to let Wendy go.
Okay. Wendy.
I gave some of mine already.
All right.
So I'm going to throw the ball back to her on that.
All right. The rubber's hitting the road. We got to get our students involved in research. Final words.
So find a mentor. I think find a mentor is the best place to start. I will tell you, I'm just gonna, toot the horn of my students. And this was completely unsolicited. 7 students came to me within the last couple weeks because the abstracts were due for ACFAS by the end of last month or middle of the month. And I had 7 of them come to me and say, hey, we want to put an abstract into ACFAS. Can you help me? I'm like, yes, I can help you. That is amazing. And now I'm helping to find, money to support them to go. And they came and I was like, that was like a proud mommy, because I could be their mom at this point in time. It was kind of like a proud mother, all my little students are coming and they want to have abstracts. They want to have posters. So find a mentor, someone you could rely on. And again, start simple. Start with just a simple question or a curiosity. You could do a lit search if you have, a presentation or a question about a disease state. A lit search can lead to a great abstract or poster, but start with a poster. And then you could always parlay that into some sort of publication, like we talked about, even a periodical publication, or if you do a really good lit search and meta-analyses or a systematic review, you could even potentially publish that in a peer-reviewed journal. So just have a question and find a mentor and work with someone. And, all of us on this call are happy to work with students, and they don't have to be within our specific colleges either. I'm happy to really collaborate. And I think that's another thing. I think our colleges could collaborate a little bit more on these projects as well. Sometimes we find ourselves a little bit siloed, but I think that's what we should encourage at the student level.
Well said. And those students are going to be the future leaders in our profession. That's great.
Absolutely.
Wow. Well said, Wendy. I have nothing left. We're running out of time. Wendy, we are so grateful for you carving time out of your schedule to join us on Dean's Chat. Thank you.
Oh, absolutely. It was a pleasure. And we could talk for another hour.
Well, we'll get you back on. We can do that again.
Get part 2. There
you go. Wendy, part 2.
I love it.
And we're going to be sending you a Dean's Chat cup. Joe, I think I got mine here. It's great for morning or evening, whatever you like to drink.
All hours.
Something a little different in the morning than the evening, but it's all good.
It still will take care of it. All right.
I love it.
Right on. All right. Well, to all of our listeners out there on Spotify and Apple Podcasts, we're so grateful for you listening. Please give us a 5-star rating and perhaps even leave a couple comments. And if you're watching on YouTube, we'd love for you to become a subscriber. Until next week, everyone, cheers.